Stents are placed in the arteries of the heart to keep the vessel clear of blockages. Dr. Donald Mahon of St. Joseph Hospital in Orange discusses new techniques used to improve the stent's long-term effectiveness.
Drug-eluting stents are the latest innovation or improvement on the procedure of angioplasty. Stents are stainless steel devices that we implant inside the artery, which have been extremely helpful in keeping these arteries open during the angioplasty procedure. One of the problems with these regular bare metal stents was a recurrence risk. Somewhere between 15 to 25% of the time, these arteries would re-narrow from scar tissue within the stent. Drugs have then been developed and techniques perfected to put the drug on this stainless steel stent to allow it to elute or dissolve into the arterial wall and inhibit the scar tissue formation. And the process, what we call restenosis, has been reduced dramatically as a result. People wind up with a stent in their arteries to the heart for several reasons. Usually they either present with episodes of chest pain, angina. They may have had a stress test which was remarkably abnormal, which led them to come to the hospital for the angiogram electively, and the physician, the cardiologist, finds the blockage that corresponds to the abnormalities on the stress test, and they may get an angioplasty and stent at that point. Another subset population comes in with either a myocardial infarction, a sudden heart attack as their first presentation. They get treated either with drugs to dissolve the clot, or they may go directly to cardiac catheterization, and they may have an angioplasty and a stent performed at that time. We have so many devices available for us, between balloons and lasers and drills, that if we select our patients properly and select a reasonable person to undergo this procedure, should be at least 95% successful. Getting the stent implanted then at that point should also be very close to 95%. Not all stents are created equal. Some are more easily applied to difficult anatomy, difficult blockages than others. We're doing more and more complex patients, and in fact, we're seeing a reduction in the number of bypass procedures as a result of improvements in our technology, specifically drug-eluting stents. I think will clearly make a dent in the number of patients that require bypass surgery. You put in a stent, you expect it to, it's going to be there forever. There's a recurrence risk even in these new drugs-coated stents. And interestingly, this evolves as we put it into more and more complicated patients. Early studies suggested it could be as low as 5%. Maybe it's going to be closer to 8 to 10% recurrence risk. People develop blockages not necessarily even inside the stent, maybe on either edge of the stent. So recurrence can occur, but it's significantly reduced. There's still a possibility that within the first 6 to perhaps 12 months, a person may get recurrent symptoms. But that 5 to 10% statistic is a huge improvement over previous procedures for us. The wonderful thing about angioplasty and stents is basically it can be an outpatient procedure. You can come into the hospital in the morning and conceivably leave the next day. Now, the same day. For convenience, for pure reasons, we frequently keep them in overnight. But most patients will have the procedure done one morning, they're gone the next day. Maybe you'll tell them not to lift anything heavy for a couple of days, but for the most part, they can be back at work in a couple of days. They can be back in the gym within a few days. It really doesn't slow them down at all. A crucial part of this thing is not just treating the lesion, you treat the disease. These patients need to be on drugs to lower cholesterol, aspirin, drugs to reduce clot formation, blood pressure pills, whatever it takes to make sure that they are not back again with a new blockage in the future.